Good morning, Sister MacFarlane. I gather you've a referral for me.
Yes, I do. I have a lady, 59 years old. We spoke about her at the MDT the other day. She had a stroke last summer and she's really struggling to cope after it. She's quite tearful, she's got problems with her vision, which means she can't drive, and she's really worried about her memory.
Tell me, when exactly did this lady sustain her stroke, Jo?
Round about July 13, so that's about 8 months ago.
Of course, that may seem like a short period of time, but we know from the clinical literature that adjusting psychologically to stroke takes time, anything up to 2 years. And of course, this is not surprising when you consider that stroke is the leading cause of disability in UK adults, and indeed the third leading cause of death. So in this context, getting used to the profound changes that stroke can bring for patients is psychologically very challenging. And low mood, tears, anger, frustration, anxiety are a very normal part of that adjustment process. What are the main physical effects of the stroke for this lady?
Well, there's some sensory problems with her face and her arm, obviously vision problems, and the fact that she can't drive because of the vision problems.
Okay. Paresthesia, so numbness and tingling, can be very intrusive for patients and something that it can be hard for them to shift their attention off. Deteriorating vision in the context of stroke is of course very challenging. It can impact confidence. From what you've said, it sounds as if this lady may have a hemianopia, so I guess parts of her visual field are missing.
Yes.
And of course that can impact confidence, and indeed she's been told she cannot drive. Driving is a crucial building block for both self-esteem and indeed independence. I noticed this lady's of working age, Jo. Does she have a job?
She's an assistant primary school headmistress, but she's not gone back to work yet. She feels she can't cope. She worries what people will think about her.
Okay. Psychologically, getting back to work can be very important, indeed beneficial for patients, but it has to be at the right time. And of course, given that she has concerns regarding her memory and cognition function, and also given the changes to her vision, one can see why she may not feel entirely confident at this stage to get back to work. I think also around the concerns that she has for her memory and her concentration, it would be quite important to progress a more detailed neuropsychological assessment. Do we have any cognition screening data on this lady?
Yes, we recorded her MOCA and it was 30 out of 30, which is really good.
That's a top mark on the Montreal Cognitive Assessment, which is a good choice in terms of screening cognition. One of the domains that MOCA doesn't measure, however, is mental speed. And of course, following stroke, cognitive deficits are common. We would see them in maybe 40% of stroke survivors. And mental speed difficulties with tracking group conversations, thinking at a rate one would have thought at before the stroke, that sort of problem is common. And it may be that even though she's scored top marks on MOCA, she has some problems in those areas. As you know as well, mood factors can interplay with cognition. Any psychometric data around that?
Well, we use a HAD score, and she scored 17 for depression and 15 for anxiety.
Yes, indeed, moderate severe range on both depression subscale of hospital anxiety and depression scale and the anxiety subscale. But of course we know that a third of stroke survivors develop clinical levels of depression in the year following stroke, and 1/4 develop clinical levels of anxiety. Very often following stroke, when mood is low and patients are anxious, there may be a pattern of social withdrawal and avoidance of particular situations. Is that happening for this lady, Jo?
Yes, very much so. She used to be involved in the church and she no longer goes. She's got quite a wide circle of friends, which doesn't even answer her phone anymore. She's very embarrassed to face people, and she just feels she won't cope.
Getting back to normal, facing people that we know well following stroke, and indeed reflecting on, even admitting that a stroke has happened, can be challenging for patients. And it's very important using psychological approaches like cognitive behaviour therapy to help patients to identify situations that they may be avoiding and to give them strategies to manage anxiety difficulties, strategies like relaxation and distraction, so that they can get back into those situations again. Behavioural activation therapy, a key component of CBT, also will assist patients like this lady to identify activities that are pleasurable that confer a sense of achievement. She's not going to church anymore, she's not seeing friends anymore, and these will be situations that were previously rewarding for this lady's mood. And behavioural activation therapy approaches would be one way of helping her to re-engage with those aspects. So I'm wondering about this lady's family, Jo. Is she married?
She's married, her husband and 2 teenage children. They're all very supportive, and in fact her husband goes to all her appointments with her.
Excellent. It sounds like she's got a close family unit, Jo, and that will be helpful for this lady's adjustment. And indeed, families have to adjust to stroke as well as patients. And it may be that there's been a degree of impact of the stroke in terms of this lady's relationship, both with her husband and indeed with her children. I know you reflected earlier that she's the go-to person in the family, and it may well be that as a result of the stroke, it's been harder for her to maintain that familial role, and part of therapy could be to address that aspect. Tell me about her support network, her social contacts, Jo. It sounds like she's fairly linked into the church.
She's always been very involved in the church, readings on a Sunday, helping out at the Sunday school. Again, that's something she's withdrawing from at the moment. She has a wide circle of friends, both from work and the church, and the elders at the church are really missing her input.
As you know, a good social support like one that she clearly has is protective against depression, and I think encouraging her to get back to those situations, as you rightly acknowledge, will be very, very important in terms of her psychological adjustment and progress. Indeed, even having people not within the family that one can talk things through with is very, very important to further progress through the psychological effects of stroke. I'm just thinking, with her mood being as low as it is, indeed moderate severe range on hospital anxiety depression scale, is she showing any evidence of unhelpful negative thinking?
Yes, she's very negative about lots of things. She feels that she can't cope, she can't do the things she used to do, and she feels that she's a burden for her family.
A sense of permanent inadequacy, a sense of being a burden on others and a burden on family. These are thinking patterns that commonly present in the context of depression after stroke. And it's very important that using cognitive therapy approaches, psychologists help patients to identify when negative thinking like that is occurring and to begin to gently challenge some of those thoughts and to make sure that that pattern of unhelpful, unrealistic thinking isn't crowding out more rational thought. Thoughts are opinions, they're not facts, and it's very important that patients are helped to appreciate that that's the case and to notice exactly what it is they're thinking when their mood changes for the worst. Thanks, Jo. This sounds like a very appropriate referral. It sounds as if the psychological adjustment that she's had to make to her stroke has been a challenging one to a degree. I have some concern around her mood. It sounds like it's fairly low, and it will be important using a cognitive behavioural therapy approach to help her to both reapproach some of the situations that she's avoiding and indeed to reflect on some of the patterns of thinking that she's showing that may be maintaining her low mood. I think from a cognitive perspective, although she scores well on Montreal Cognitive Assessment, it will be important to look at that aspect, in particular regarding work return, and indeed with her visual difficulties impacting her confidence. Although I would assume it would be beneficial for her to get back to work, it will need to be at the right time. How do you think she feels about coming along to a psychology appointment? Have you asked her if she's comfortable with that?
I have discussed it and she's agreed to come. We did have to talk about it 2 or 3 times because at first she didn't think she had a problem that would be helped, and fear of the unknown, she just wasn't very sure what was going to happen.
Yes, indeed. The thought of seeing a psychologist can be a little challenging. Certainly, as you suggest, it's an unknown aspect, and indeed over the years there has been somewhat of a stigma around working with mental health professionals. In my experience, most all of the patients, once they get along and talk to the psychologist, find it a reasonable experience. I look forward to seeing this patient when she comes to clinic, and thanks very much for making this referral.
Thanks very much.